Hi guys and welcome. This is Jen Gaeta Siciliano, artist, memoir writer, bipolar psychiatric survivor, and your host of Not As Crazy As You Think podcast, the place that offers an alternative perspective on mental illness, highlighting creativity, non-conventional healing, and breaking on through to the other side. If you are ready for a new narrative on the mental realm that celebrates crazy and cool without penalty, then Not As Crazy As You Think is for you. Okay, so now we're here with Mark Ragins, psychiatrist, correct? Yep. And someone who is really into being on the front lines of helping the, I would say, less fortunate. You're doing a lot of work with the homeless right now.
Yeah, my current job is to work in Los Angeles with the street medicine teams, actually walking around finding people in encampments and tiny homes and stuff like that.
You know, this is incredibly compassionate coming from, a person who's won plenty of awards, been in the field in so many different ways, to take this jump onto, reaching this group of people that's often completely neglected by society. Like, what made you make that choice?
So, two things. One is I've always worked with people with severe mental illnesses, and in our society, severe mental illnesses make you very poor.
Yeah.
So I've always worked in the public sector, people in and out of jails or hospitals, or homelessness as a rule. In Los Angeles, homelessness has escalated over the last 10 years or so to much worse. The reason I took this particular job is because I didn't want a job where I was sitting in a clinic 15 minutes doing med checks one over another. And this one, they allow me to get out of an office, wander around, and no one expects me to be efficient. Mm-hmm. So I'm permitted to sit on a street corner or next to a tent or in a park or something for an hour and a half talking to somebody who most of you would probably avoid. And in fact, actually takes a fair bit of undoing social learning. Those are precisely the people you walk away from that your mom told you not to talk to in the park.
Right.
But to get to know them and try so they're seen, to bear witness to their struggles, and also to try to give back some sense of what's going on in their lives, a story of their life, not so much a diagnosis, but a story of their life of how they got to this point, so they can put together and make sense and say, hey, there is a chance the next chapter of this story, I could take control of and get off the streets. How could that be? You only get hope from knowing how you got to where you are now. Let me say one last thing about the compassion thing is, we're presently struggling that a bunch of people feel compassionate towards people on the streets. I want to help them. Then a bunch of people feel like, can you get rid of these people? They're ruining my life. And frankly, most of us do both. Yeah. At different days, different times of our lives, our moves, whatever we're about, what that person happens to look like. But it's impressive the effect when when we got a medical doctor or something and doing street medicine, and they're bandaging up somebody on the corners laying there, and the people around see the care being given to them. People come up to us, and it brings out the compassion in the onlooker. Wow. That we're treating them that way.
That's amazing. I mean, because you're not only helping the person, but you're in some way, exercising this staging of this is what it looks like to be compassionate. And many people don't see that on a day-to-day basis. Right. So especially going right to the source of the problem, right? The unhoused are on the streets. You're not letting them come to you. You're going to them.
Yeah.
I think that's remarkable because I mean, honestly, from me to you, I don't think most people do this.
In it isn't as remarkable in Los Angeles. Maybe, I don't know about other cities, but we have at present, I'd say 100 different teams.
Wow.
Of people talking to homeless people, because we have 60,000 homeless people on the streets.
Yeah.
And among that group, there's maybe a half a dozen or 8 psychiatrists. Among that group, there's maybe 8 or 10 medical doctors and some nurse practitioners, and mostly there's a whole bunch of people who have some lived experience that makes them compassionate, be able to go against our normal social revulsion to talking to these people. Many of them were on the streets themselves, or they had family members, or they've been through drugs or something, and that can be very hopeful as well. I'll often pair with someone like that. So I'll say, hey, you think you can't get over this, but, Laser here with me. He was here in Skid Row for 2 or 3 years. He got through this process and stuff. He got the job down in that place. He still hangs out and plays basketball with them to be able to do things. You know, you don't have to be like this forever. And that's a message you can get from a lived experience story of hope that me as a psychiatrist coming back and being, you know, commendable in society's view just doesn't carry the same emotional weight.
Right. But I got to tell you, you know, I wish that New York could take some lessons from this, because that's not what's going on here. They are putting away the homeless just to take them off the streets so that people don't have to see them.
And to be fair, that's we've created 10 to 14,000 transitional shelter things in tiny homes, and this is actually, for many of the people, it's actually helpful. It is better to be inside than to be,
of course,
on the street. It is better to the people around, but there's a difference between being homeless and houseless. Mm-hmm. Many people have a home on the street in the encampment. When we do a sweep or something, move them around, make them keep moving, we break up their home. And then even we put them in a tiny home or in a transitional shelter, that's not really a home.
Right.
Or as one lady said, this is like a storage facility for people you don't want to have around your house anymore.
Yeah.
And it's literally made out of the same things that storage facilities are made out of.
Right.
And hopefully the next iteration would be, so can we run these places as communities? Can we run these places as homes where you can actually decorate, have people around? Can we run these places as a place where you feel it's your place, your home, where there's government of the people who are living there, making their own rules, making their own activities, empowering, having roles, hiring them as jobs to run it? Can we make them more engaging in that way? Because right now we're concerned with, we got a bunch of people, we got them off the street. These are people who do a lot of stealing, a lot of drugs and stuff. We better make sure they follow the rules and don't bring other homeless people, make their own case, and not too much drugs. Let's make sure there's a structure everybody's following up, which to them feels like jail.
Yeah, yeah. Well, listen, it's a step in the right direction, which is great, because you have to envision something, right? First.
Right. And it's better to be off the street than on the street for many, many people.
Right, right.
Not everyone, but many. So
let's talk a little bit about your talk that you just gave today at the ISPS Conference, Journeys Beyond the Frontier, a rebellious guide to psychosis and other extraordinary experiences. This is the title of your book. Mm-hmm. And, you know, you were talking a little bit about the structure of it and everything. And what I loved is that you really believe that the story of our lives is one of the most essential pathways, and how we create the story of our lives is one of the most essential pathways to knowing oneself and to healing possibly from a lot of these conditions.
Mm-hmm. Yeah. So if you take someone and they're terribly, actually, I'll give an example from the street just a few months ago. This man comes, and he'd agreed to go from the streets to be in a rehab to get off of fentanyl and meth. And they'd given him some Suboxone to help do that, and he was there for the first day, and he said, you know, I've been depressed my whole life and anxious my whole life. Can I see a psychiatrist about some medications? And it comes from no reason. I've always had it. When I talked to him, his story was, I said, did it really, your whole life? Like when you were 8, when you were 6? No, it wasn't back then. Well, what was before? Well, I used to live in San Diego, and he was a really athletic guy, and he was a swimmer and stuff, and surfer and things, and his parents had a terrible divorce, the kind of terrible that the dad snuck them away to a different state in the middle of the night. The mom wouldn't know terrible, ruining his whole friendships and his athletic career and stuff. And as a result, he went on to be successful in running a car dealer, I think, or something, and he still wasn't anxious or depressed and all this. I said, but it's not your whole life, really. And he promised himself he would never, if he had children of his own, he would make sure his relationship was strong so he wouldn't leave them in the same spot. So I said, when did this really start? Well, he did get married. He stayed with the woman for like 5 years before they had kids, so make sure he kept his promise. And the kid they had was born with some really severe, weird, congenital physical illness. So he was like in a wheelchair and weird the whole time. And since his whole life had been about this physical thing, things I'm going to do with my son stuff, he couldn't handle that.
Right.
He starts drinking some more. He ends up in trouble, and he loses his job, and the wife gets mad and stuff, loses the whole thing, and ends up not there and ending up on the streets, and now been 4 years on the streets away from them. And that's when he's been feeling depressed and anxious since that happened.
Right.
This isn't for no reason.
Right.
This is, God has a way of giving us exactly what we promised not to do as our injury one.
Right.
But B, he can't forgive himself for something I'm not sure I could handle.
Yeah.
And also, once we put this together, we said, you know what? So if that's what's going on, you can't go back to or it's a shame to go back to his wife and kid. And I said, he still needs you, actually. But if you come like this begging ashamed, it's not going to work. It's going to be a bad emotional. You have to become okay with it and forgive yourself first and come from a positive spot.
Right.
And you actually know how to do that because he'd been in AA stuff. AA is terrific for telling stories that are terrible and things you did and getting acceptance and forgiveness from the group until you internalize it yourself.
Yeah.
It's an incredible thing they do. I said, so you don't actually need an antidepressant. You need to work on being able to forgive this, telling that story over and over again to the meetings to get the healing from people around you while you're getting off of it. And then when you're at peace with it, then you're at a place to reconnect and your son could still use it. That was about an hour and a half to get to all that. But if you just say you have a major depression or social anxiety and along with these things, or you have a speed inducer, I mean, here's your Prozac.
Right.
You had to know this. What we call mental illnesses now are the effects, not the causes.
Right. And that's a big thing because I love how you put a lot of emphasis on this. A lot of people who are, say, in the field and who are dealing with lots of different kinds of manifestations of this, they are looking at these things as symptoms, and because they're not going to the story, the reductionism is beyond just biology. It's like almost like lives have no meaning at all. Mm-hmm. And I think that that's what a lot of people feel with this. One of the things, though, that I appreciate that you mention in terms of why people don't go there in the field, they don't ask enough questions, are these like these barriers that you mentioned that prevent this from happening, this connection. So this fear, this sense of like incomprehensibility, unconnectability, hopelessness. Can you speak about that a little bit?
Right. So the fears I was talking about in that thing were specifically about psychosis. Many people who want to become psychiatrists or psychiatric therapists, they're fine with depression, anxiety, or trauma, or personal things, or
right.
eating disorders, or obsessive-compulsive, or a variety of things. And frankly, all of us are fine with some things and not some things.
Yeah.
We all have edges. Just because we're tolerant, we can accept or include one thing doesn't mean we can accept and include everybody. Even
right.
AA can accept people with alcoholism, but not everything.
Right.
So psychosis is way on the edge. And there's way more people interested in psychosis as a phenomenon or a symptom or a brain thing or how could you do these weird things, or it's just fascinating. They want to study psychosis rather than spend time around people experiencing psychotic symptoms. Mm-hmm. To actually be around the people, the barriers you just listed, the first thing is we tend to be frightened of psychosis. Mm-hmm. We're taught to be frightened that they could be mass murderers. We bring the police out. We hospitalize people for dangerousness. We act like half a police state with this stuff. But also we're taught, don't talk about somebody's delusions or hallucinations. You'll feed into them. Mm-hmm. You'll make them worse. You could trigger them. You better not do this, and keep a professional distance. You don't want to get in a psychotic transference. They're going to get delusions around you. Then they maybe trace you back at home or do stuff. You better keep a distance from these people. Two is, they're super hard to understand anyway. There's no meaning to any of this stuff they're jabbering about, all these things. Don't bother with that because you don't need it to give them pills or treatment anyway. It turns out the content of the voices isn't relevant for their pill choice anyway. Mm. The entire Hearing Voices network is growing dramatically because it's founded in There's meaning to these voices. If I can understand them, I can come to terms with them. I can learn to live with them and the suffering they go. And that's an unusual point of view, even though it's like, that sounds like, wouldn't that be the first thing you do is listen to them and see what they mean? No.
Right.
The third barrier is that we have trouble relating to people. Like, even when I'm walking with the street team, when we see someone there talking to themselves and jabbering and bringing arms around, most of the other people around do not want to talk to that person.
Right.
They can handle the gang person that's there, the person who's high that we're handing out needles to. They can handle the person who's using meth while she's pregnant and torturing her fetus. But that guy's crazy.
Right.
Psychosis is off the edge of the map. It's like where, remember the old medieval maps? It's where the monsters lie.
Yeah.
You better not send your ship over there.
Right.
Except that most people with psychosis, if you spend any time with them, you can relate to the actual person instead of the psychosis. You sit there for a while and connect. Maybe it makes sense for a while, maybe it doesn't. Maybe you're just doing something together. Maybe you're going for a walk. Maybe you're sitting together. But you can start to build a relationship and start to relate to the healthier parts of them and connect. And the fourth barrier, the first one was fear, one was incomprehensibility, one was can't relate. The fourth barrier is hopelessness. We assume that the people that we see who are hearing voices are just going to chronic deteriorate and they're going to get worse and worse. This is going to get worse. This is like an idea from Kreplin in 1890 or something, talking mostly about people with neurosyphilis.
Right.
The research that shows that people 2/3 recover. They work, they have lives and things, if they have the supports to do things.
Right.
People had far better outcomes in 1850 in America with moral treatment than they do today.
Right.
Actually, people probably had better outcomes just 30 years ago before they all became homeless because the disability money we give them isn't even, it used to be 1/3 of the poverty level. Now, and I remember one guy with psychosis said, so why does being disabled mean I should be at 1/3 of the poverty level? I said, I don't know, Jeff, that's just the way it is. Now I have to say, you have to be homeless because we're not even giving you enough money to pay the rent in Los Angeles anymore, and the waiting list for Section 8 is too long.
Wow.
That's making their outcomes worse. So this hopelessness, well, they weren't going to do anything good anyway, so why bother putting good money after bad?
Yeah.
We desperately need people like you and the other people at this conference to say, no, wait a second. People can recover. They can have full lives.
Right.
I'll tell you one quick story about this. A number of years ago, we were in Sacramento advocating probably for more money. We're always asking for more money. And I'm with several people who all had psychosis. And they had done this advocacy a lot. I was like a newcomer. I'd never been there. And they're telling their stories and asking whatever the bill was we wanted to pass and doing these things. And it gets to my time, and what am I going to say? So I said to the Congress, when you think of people with schizophrenia, people with psychosis, your vision, what comes to your head, is it these 4 people here who are sitting as advocates telling stories and looking together and stuff. One of these people I'm actually prescribing antipsychotics to right now.
Yeah.
I go, no, it sure isn't. That's not what I think of.
Wow.
We don't, our image doesn't, our image is so embedded in hopelessness and the old institutional images.
Yes.
Or in today's homeless images that it isn't even part of our picture to aspire to what's possible.
Yes. And you know what? I mean, hearing you talk like that, it gives me compassion for the person on the other side who was evaluating me at times, because that's what often people feel when we're in the position of, listen, psychosis comes upon you. You don't understand it sometimes, and it's something that hits you by the, on the side of your head, and you're just taken in by it, and we all have our own interpretations of it at this conference. But the truth of it is, you are out of control. And it may seem from the outside, if a person is out of control, that they're just long gone and there's just no help that can be given to them. But what you are doing, and which I want to bring to attention now, is that, by putting like real true meaning behind this, you are allowing healing to take place. You have this thing called the psychosis triangle. I want you to speak about that a little bit, because I think that that's key. I know I wasn't even able to begin to think about getting off meds until I had other areas like relationships and self-identity really powerfully strong so that I can make a move. This is a big thing because if we talked about this more in healing, I think like psychiatrists could be more on board with this.
So I think so. The idea here is back to my conception that says these conditions are the effect, not the cause.
Right.
So we say, so schizophrenia is psychosis has gone on for at least 6 months. What caused that?
Mm-hmm.
And I believe you have to have 3 things go wrong to get in that position, all at the same time. You can start with any one of the 3, but all 3 have to go wrong. One is the one we normally focus on. You have problems with experiencing reality. You got problems with hallucinations or delusions or paranoia or something like this. The other 2, though, one is you tend to lose your sense of self. When you said, I'm out of control, I'm confused, you don't know what you're about anymore. And sometimes actually being thrown in a hospital with a bunch of other people and institutionalized and being given a diagnosis that's hopeless and adding a bunch of meds that may fog your brain, that can make you lose your sense of yourself even more.
Mm-hmm.
And the alternate self that we offer you that says you can be a chronic psychotic patient living in poverty and abandoned care and disabled for the rest of your life may not help you regain much of a sense of self.
Right.
That may not be appealing for many people.
Right.
But and then you say, never mind, I don't want to be around anymore, and you run off to the streets and see if you can do it yourself.
All right.
You lose your sense of self. The third one is you lose relationships. Become either very isolated, you get up backwards, so you're up at night and asleep during the day, you stop showing up, stop keeping yourself clean, you get real paranoid other people after you, and you get it all by yourself. Terrible isolation in itself can make you lose track of reality.
Sure.
You start talking to yourself because I'm by myself. Any of the 3 can be the one that breaks it,
mm-hmm.
that starts the process. You use too much speed. You have too much imaginary things going on. Your subconscious too much stuff, and you lose track of reality.
Mm-hmm.
Or you get lost. Why does this happen? Tends to be in adolescence and early 20s because that's when you're trying to form your ego identity, and you didn't succeed.
Right.
It didn't work.
Mm-hmm.
You got fragmented. You too much trauma didn't get to where. Or your relationships, you got thrown out of the house. You ran away from sexual abuse or traumatized, you grew up in a bunch of foster care, you were thrown in prison, your relationships got all messed up. Anyone can start this. And then they start falling like dominoes.
Mm.
Not for everybody.
Right.
Some people, just one thing goes wrong, and you have an identity crisis and you pull it together eventually. You get messed up on a bunch of acid and you pull it together eventually.
Mm-hmm.
You have a bunch of spiritual experiences and you integrate them interestingly, and you say, wow, that tells me I should go to the priesthood. That's retaining your relationships in yourself.
Right.
But if all 3 fall apart and stay falling apart, that's what we call schizophrenia.
Right.
And then when you meet someone like that, our normal approach is to say, we're going to fix just the experiencing reality one. We don't even pay attention to the other 2. Mm. And we may even make the other 2 worse by locking you up somewhere or having you live in a segregated setting or by taking away your identity.
Right.
Then our outcome is, well, about 80% of people can't get off meds because the other 2 sides of the triangle are broken.
Mm-hmm.
If instead you can use any of them to get back together. Weird practice in rural Finland that's getting a lot of play is open dialogue.
Yeah, yeah.
They do not start with the meds or the experience. They start with the relationships.
Right.
They say, all right, everybody who cares about this person, come talk with them. We're really good at keeping relationships going, and we'll keep meeting with you every week, how you're going to keep them going as a relationship, as an identity, and keep them in the community, and we'll keep doing this for months and months to be able to do this. Outcome of that, 80% of people never need to be on medications, and the experiencing reality problems go away within 6 months.
Right.
Why? Because the other 2 were focused on.
Right, right.
You can focus on any of the 3. We got a lot of people say they're non-compliant because they won't take meds. All right, how about the other 2 dimensions?
Right, right.
Can we work on something else instead? Start with but our programs basically only fund and focus on the one dimension.
Yeah, yeah. Well, I mean, the approach that you're taking is so compassionate. And I just feel that, one of the things that is lacking is this sense that we are people. Even when we go through this, we're not necessarily broken people. I'm sure you've heard of Joanna Moncrief's recent or last year when she put out that study that kind of brought to light in many ways, for at least I know the psychiatric fields were aware that there is no real true chemical imbalance. But, she speaks of a drug-centered model as opposed to a disease-centered model when it comes to drugs. And it seems as though you kind of lean towards a drug-centered model more rather than disease-centered, because the drugs can be helpful to get people stabilized, to get those other two areas under control if, all three break down. And yet what we've, I think, just focused on so much is this is the disease. These things are treating the disease. But we know that, just because we've changed the words, say antipsychotics, to sound like it's actually fixing the psychosis, that's not what these drugs are doing.
So this is an excess in medicine overall, that we market pills for treating illnesses. And many of our illnesses are actually consequences. So, for example, I take a pill to lower my cholesterol because one of my heart arteries clogged up. They didn't figure out why my cholesterol is lower. The answer is probably because I eat hamburgers. And I didn't fix that. They gave me something to deal with the consequence of this. You don't need to need the cause. You can even name this consequence of disease, hypercholesterolemia.
Yeah, right.
Similarly, I have eye drops to keep the pressure down in my eyes so that I don't get the name just went in my head. So I don't get blindness from the pressure destroying my eyes. Each of the drops works by a different mechanism. Nobody has any idea why I have high blood pressure in my eye in the first place, nor are we matching it to. This is normal medicine.
Right.
Many of our illnesses are actually the consequences, not the causes. Hypertension, diabetes, epilepsy, they're the consequences. So when we say, well, you're putting a Band-Aid on it, that's not a bad thing. It's not a bad thing to keep my cholesterol lower so I don't have another heart attack. It's not a bad thing to keep my pressure in my eye lower. This is fine. So if you're in a position that says, I'm losing track of reality, or I'm getting over confused, or my subconscious is exploding in my conscious mind, or I can't keep my thoughts together, it's too structured, I need more glued together, I'm not fixing the underlying problem. Mm-hmm. The pill doesn't care what the underlying problem was. It could be used a whole bunch of meth. It could be that you had terrible childhood trauma. It could be you have a breakdown after grief or loss or something. It could be it was a spiritual experience. It could be a psychiatric illness. It could be a physical. It doesn't matter in terms of the meds helping.
Right.
But don't confuse that with actual healing.
Right.
But most of our medicine doesn't heal anything.
Right.
For anything.
And we, like, as you say, in general, it's the whole approach of medicine. We are over medicalizing everything. We think we're being healed by taking all of these different medications, psych meds aside. We have gone in the direction, say, of holistic healing on many levels in physical illness. But this idea with holistic healing, in a sense, for mental illness is still a little new. And you see it here. Everyone's talking about all these different ways you can heal and all these different modalities. I mean, do you think that we are starting down that path where that can be more acceptable?
See, I think treating it holistically is the norm that that the system is trying to undo. Mm. Until maybe, 100 years ago, hardly anybody would have thought that their problem was due to chemical imbalance in their head.
Right.
We've been socializing, or if like my college students, we've been colonizing this approach to doing things, so more and more people buy that.
Right.
When somebody comes by and they say, my family doesn't believe in mental illness, we consider that a sign of ignorance, a sign of stigma, a sign of problems. We don't say, so how does your family actually deal with people who are stressed or overwhelmed? How do people deal with someone's hearing voices? How would your family deal with this? Mm-hmm. If the answer is my family deals with it by locking people in the closet and never doing the back and shame, that probably is not a good indigenous practice.
Right.
But if the answer is my family comes together and does a large sand healing thing and puts us together as a group and talks the answers and gets it healed and pulls it together, and we have substantial effects and we welcome them back and we feed them and keep them well, that may be a tradition worth keeping.
Right.
We act like we're inventing holistic or spiritual things rather than undoing the process of destroying them.
So where do you think it got destroyed? Do you think it was with the DSM-3, like really focusing so much on the biomedical perspective? Because that's where they added a lot of, they took away context,
So that was the most dramatic battle in the war. But instead, and don't necessarily blame this all on psychiatry, because our society doesn't blame in general. If you think about healing people in general, you can do this at an intellectual level. You can help a biological level, you can help with pills. At an intellectual level, you do cognitive therapy or work on your thinking, or let's write down the positives and negatives or change your behaviorals. You can do it on an emotional level. Let's do something about compassion or caring or working through your shame or your trauma or helping you find parts and accept them. Most people think of therapy as being emotional, even though it's more and more drifting to being intellectual. Or you can heal on a spiritual level. You can do things that have to do with Reiki or prayer or spiritual healings. All these things need different relationships, different trainings, different expertise.
Right.
In 1850, our country relied mostly at the spiritual level. It was moral treatment. We were a very religious country. And the outcomes for psychosis in small moral treatment hospitals in the 1800s, mostly Quakers, was 2/3 recovered and got out of it in 6 months.
Yeah.
Better than our outcomes today. We moved on as we decided religion, spirituality, and we've left that behind as our society. There's lots of people spiritual seeking, but our institutions have failed.
Right.
Then Freud comes along and says, this is all about our emotions. And then saying we bring all kinds of emotional stuff, and we spend about 50 years in that trying our emotions to figure out what happened in our childhood and stuff. And people say, this is kind of too messy. I don't like going through this. Isn't there an easier way? I hear you guys invented some pills or stuff. Or can't we just change our behaviors and don't have to think about thinking? And in the 70s, we switched to cognitive behavior therapy. We switched to biology. We switched to reductionistic analytic things. And medicine as well. So don't think about the emotions. Let's make it all physically based. We want to be real doctors. The key point in that, particularly about to eliminate the emotional level, was the DSM-3. The switch from 2 to 3.
Right.
Because 2 said these things are reactions to things.
Right.
They had it was schizophrenic reaction, manic reaction, depressive reaction. By DSM-3, these are syndromes on checklists and symptoms and assumed to have biological or genetic causes. And the biologist destroyed the psychoanalyst and the emotional one drifted away.
Yeah.
Now we're saying, you know what? I don't think I even want to pay attention to my behavior. You want me to stop eating hamburgers? You want me to get away from this bad affair I'm having? You want me to do something about the wealth inequality so people aren't homeless? I don't think I want to do that either. Can't you just give me pills for all these things?
Right.
We are stripping away these layers and then wondering why our treatments are less and less effective.
Yeah. It's great to speak with you about it, because you are on literally walking the pavement with these people. And so you're seeing the social problems. And so much of it has to do with, people not being able to sustain, their finances, their structures in life. A lot of people feel very put out by capitalistic structures right now. That's coming up more and more in these experiences with mental distress. So I just find it to be a relief to hear someone like you give so much weight to that in your practice. One last thing I do want to bring up, because I think it is so important, is this idea that you are pushing, that people are creating a personal formulation. And I like the idea also that you want them to give a title in their own words to what this personal formulation is. Can you speak about that a little bit?
Sure. So, I gave an example back a few minutes ago when I was talking about the man with the son. So you could give him a diagnosis of substance abuse and addiction and major depression and generalized anxiety or something, or PTSD, or so. You can give these diagnoses. Or you can give that story I gave you of his life and then name that story. The man who couldn't handle the physically disabled child. That gets to the core of what's wrong. That opens it up for the possibilities of emotional or spiritual, intellectual healing. All these things become available now that weren't available with a depression, major depression for unknown, because I just have it and I've had it my whole life. That gave the story, a name of the story in a way that reflects their view of things. And I can have a menu that says, the name of your story is person who inherited weak chemicals from your family members and it was doomed to happen to you sooner or later. That could be the name of your story too. And probably is true of some people. But when we've cured a whole bunch more cancer than ever before by breaking it down to lots of little ones. Psychosis, and lots of different causes. Psychosis, we refuse to break down. Schizophrenia, we don't break down. That isn't a breakdown, schizoaffective and bipolar.
Right.
That's not a breakdown.
Right.
That's not based on different causes and things. If we break down these journeys people are on. But the most common reason for getting psychotic, for hearing voices, is grief.
Yeah.
Half of everybody, when someone close to them dies. But remember the other two sides of the triangle about your sense of self and your relationships. You can lose yourself. It's like part of me is gone when my wife is gone. I can't, and some people do die as a result. Or I can't go to work, my relationship. But we have social ways of intervening. We don't even need to go to a professional for this. We already have people who bring by casseroles to eat. We have people who say, I know what you're saying. They listen to your stories about your wife forever. You get to go to a gravesite. A priest manages to help. Your boss gives you grief days off of work. There's religious. We have enormous ways of helping those people recompensate. Why? Because it isn't frightening. It isn't incomprehensible. We have relationships with them, and we're hopeful about it.
Right.
We got through the barriers.
Yeah.
The other causes are all more difficult. Childhood trauma is more difficult. Using drugs is more difficult. Mental illness is more difficult. Physical illness is more difficult. Losing your balance as you're growing and developing, until you end up, in Joseph Campbell's words, psychotics drown in the same deep waters that mystics swim gracefully. All of those things require, if you're going to journey with someone and help them heal, you better bring some good luggage along.
Right.
Whether the luggage is, I'm trauma-informed so I don't get hurt myself. I'm not acting too coercively so I can do medical model things. I'm not being too proselytizing so I can do spiritual things and help you have your own path. Each of these things requires luggage so that it's your journey, not mine.
Right, right. Well, that's really, I think it hits it on the nail. It hits the nail on the head, because that's what I loved about it. I said, many people with lived experience feel that the interpretation, say, of the label or of what this thing is always in the hands of the hierarchy, right? And it's so much more empowering, and it gives much more hope to the person, and quite possibly, like, really the true beginnings of the path to healing, if they could be involved in the process of telling, giving the true interpretation of what's happened to them. So I have to say, I really am taken by your work. I am purchasing your book. Let's do a little plug.
The name of my book is called Journeys Beyond the Frontier, A Rebellious Guide to Psychosis and Other Extraordinary Experiences. It's on Amazon. You can get either a Kindle one or a paperback. Don't be intimidated by it's long. It's easy to read, and it's filled with hundreds of stories of different people, different journeys. You can read parts that apply to you and leave off parts that don't. It's designed to be read by people who are going through this themselves, family members, concerned community people, professionals, anybody. It's not written in any kind of jargon language.
That's great. And where could people follow you? I mean, do you have a website?
I do. There's a website, markragins.com, which you'll find a whole pile of articles that I wrote in the 27 years I worked at the Village, and then a few when I worked at Cal State Long Beach as a student psychiatrist. And I'm a little bit lazy lately, but I'll gradually put up ones about the street medicine work as well. There's a few videos there of me doing some trainings as well. If I was better at the technical parts, it would actually look prettier, but it is what it is. So you can find the things there. And if you think that book is way too long, there is a short book that's on that website called A Road to Recovery that basically takes Kubler-Ross's idea of these stages people go through in death and dying. Remember this about the anger, denial, depression, bargaining, and acceptance?
Yeah.
I think I did them out of order there. But that people go through. There's also stages to recovery that people go through about hope and empowerment and self-responsibility and meaningful roles in the community. That if you don't want to read the longer one, that's got some stuff that I wrote quite a while ago that you can download from the website.
Oh, great. That sounds great. Well, Mark, thank you so much for giving us your time and your insight into this. I really appreciate you and what you offer. Thank you.
You're welcome. Great meeting you today.
Thanks for listening to Not As Crazy As You Think, and don't forget to subscribe to my YouTube channel. And remember, mental health is attainable for anyone, especially those labeled with mental illness. Until next time, peace out.